Good afternoon. Today's topic of lecture is ectopic pregnancy. What is ectopic pregnancy? Normally, implantation of the fertilized ovum occurs in the uterine cavity near the fundus at the anterior or posterior. But when implantation of the embryo occurs outside the normal uterine cavity, either in tubes or in cervix or other part of the endometrial cavity, that is called ectopic pregnancy. It represents a serious hazard to the women's health and reproductive potential, requiring prompt recognition and early aggressive intervention. So normal pregnancy implanted here in the fundus of the near the anterior and posterior. But ectopic pregnancy, there is implantation either in ovary, so it is called ovarian pregnancy, in fallopian tube, so it is called fallopian tubal ectopic, in the cervix or in other part of the uterus and ovary. So implantation site, according to implantation site, ectopic pregnancy may be extrauterine or intrauterine. Okay, extrauterine outside the normal uterine cavity, uterine other part of the uterine cavity other than the normal body of the uterus. So if it is implanted in tubal, it is the most common type of ectopic pregnancy that is present in about 97% of the case. It may be in ampullary part of the tubes, it may be in stomach part of the tubes, in fundulum or interstitial. Ovarian pregnancy is found, ectopic pregnancy is found only in 0.5% of the cases. Abdominal pregnancy accounts for 1% of the total ectopic. It may be primary abdominal pregnancy when the implanted ovum implanted primarily in the abdominal cavity, or secondary abdominal pregnancy when the abdominal pregnancy occurs due to rupture of the either tubal pregnancy or ovarian pregnancy or uterine pregnancy, and this after this rupture, this ovum or fertilized ovum implanted into the abdominal cavity, so it becomes a secondary abdominal pregnancy. It may be intraperitoneal or it may be extraperitoneal when the implanted ovum, again when the implantation of the ectopic pregnancy occurs in broad ligament. So abdominal pregnancy may be primary, secondary, or secondary abdominal pregnancy may be intraperitoneal or extraperitoneal in broad ligament. Uterine ectopic pregnancy, it accounts for 1.5% of the ectopic pregnancy. It may be cervical, it may be angular, it may be cornuate, it may be cesarean scar pregnancy. By this diagram, you can see various sites for the ectopic implantation: ampullary, stomach, interstitial. This is interstitial one. Okay. This is ovarian ectopic pregnancy when implanted in the ovary. This is cervical pregnancy when the embryo is implanted in the cervical canal. And when outside this uterine cavity in the abdominal cavity, it is abdominal pregnancy. Now, what are the causes? What are the causes of ectopic pregnancy? Why implantation occurs outside the normal uterine cavity? It is due to increased incidence of PID in patients, increased PID, increased use of intrauterine contraceptive device like property, tubal surgery, and assisted reproductive techniques. Okay, so these all factors increase the risk of ectopic pregnancy. Repeated attacks of PID, repeated PID also increase the chances of ectopic pregnancy. Increase use of intrauterine contraceptive device, increase the chances of ectopic pregnancy. Any tubal surgery like tubal recanalization and other tubal surgery also increase the chances of ectopic pregnancy, and assisted reproductive techniques like implant ART, assisted reproductive technique, especially IVF, in vitro fertilization, and then transfer of the embryo inside the uterine cavity also increase the risk of ectopic pregnancy. Average range of ectopic pregnancy is 1 in every 100 normal pregnancy. Late marriage and late childbearing increase the risk of ectopic pregnancy. In ART, the risk of ectopic pregnancy is 4 to 5%, and recurrence rate after one ectopic pregnancy is 15%. After 2 ectopic pregnancy, it now becomes 25%. What are other risk factors? As I told you, history of PID, pelvic inflammatory disease, history of tubal ligation, contraception failure, like failure of intrauterine contraceptive device, failure of oral contraceptive pill, failure of progesterone only pills also increase the risk of ectopic pregnancy, previous history of ectopic pregnancy, tubal reconstructive surgeries, history of infertility, ART, particularly if the tubes are present but are damaged because of PID. This also increases the risk of ectopic pregnancy. Previous induced abortion increase the risk of ectopic pregnancy, consecutive pregnancy, and tubal endometriosis. Now, what are the causes of tubal ectopic pregnancy? Salpingitis, that is inflammation and infection of the tube, and PID. Iatrogenic contraception failure, IUCD. IUCD prevent normal uterine pregnancy. It is a contraceptive device that prevent normal uterine pregnancy. But if the pregnancy occur in presence of IUCD, there is more chances of this pregnancy to present as an ectopic pregnancy because it does not prevent implantation of ovum outside the cavity like in ovary. Okay? So if the pregnancy occur in presence of intrauterine contraceptive device, there are more chances of ectopic pregnancy in this case. Tubal surgeries, intra-pelvic adhesion. If there is excessive adhesion in peritoneal cavity, distort the anatomy of the tube, relation of tube with the ovary. So there are more chances of ectopic pregnancy, ART, IVF, embryo transfer, and gift. Other causes of ectopic pregnancy, history of ectopic pregnancy, history of abortion, previous induced abortion, increase the chances of ectopic pregnancy, developmental defect of the tubes, that means if there is very elongated tube. So in this case, embryo fertilized ovum has to travel a long distance. And before that, there is resolution of the zona pellucida and there is implantation of the dead embryo inside the ectopic pregnancy. Transperitoneal migration of the ovum. Salpingitis and risk of ectopic pregnancy increased by 6. This increased the risk of ectopic pregnancy by 4 to 6 fold to 10 fold. Why there is increased risk of ectopic pregnancy in PID? As you know, that migration of the embryo from tubes to cavity depends on the many factors like the ciliary movement, like peristalsis movement of the tube. So if there is loss of the cilia of the lining epithelium of tube and impairment of the muscular peristalsis, as occur in PID cases, this factor increase the risk of ectopic pregnancy, narrowing of the tubal lumen because of adhesion because of PID, formation of pockets due to adhesion between the muscular fold and peritubal adhesion resulting in kinking of the tube and angulation of the tube. All these factors increase the risk of ectopic pregnancy. Chlamydia trachomatis infection is the most common risk factor for PID and ectopic pregnancy. Iatrogenic contraception failure like IUCD, there is relative increase in the risk of ectopic pregnancy due to IUCD use. Sterilization operation increase the risk of ectopic pregnancy if there is failure of these operations. Use of pills, progesterone only pills increase the chances of ectopic pregnancy because it impairs the tubal motility. However, it decreases the tubal motility, so it increases the risk of ectopic pregnancy. Intrapelvic adhesion and ART. These are the risk factors for ectopic pregnancy. What are the factors which facilitate nidation of the ovum in the tube? Premature degeneration of the zonus pellucidum, increased decidual reaction, and tubal endometriosis. Now, after the implantation, what are the mode of termination of the ectopic pregnancy? Because of unfavorable environment inside the tubes, early interruption of the pregnancy is a rule, or it occurs usually within 6 to 8 weeks. The termination of this pregnancy occurs as tubal mole. The formation of tubal mole is similar to that formed in the uterine pregnancy. There is repeated small hemorrhage that occur in choriodecidual space because separation of the villi from its attachment. This form the tubal moles. So either there is complete absorption of this tubal mole or expulsion of this tubal mole through the abdominal ostia of the tube. This leads to excessive amount of a variable amount of internal hemorrhage. This resulting formation of the hematocele. Tubal aversion. This is common mode of termination if the implantation occur in ampullary portion of the tube or fundibular portion of the tube. Tubal rupture. Ischemic rupture usually occurs 6 to 8 weeks. The ampullary one at 8 to 12 weeks and interstitial rupture, ectopic pregnancy rupture at about 4 months of the pregnancy. Depending upon the site of rupture, it is known as intraperitoneal rupture. This type of rupture is common. Extraperitoneal rupture, this is rare and occur when the gland lies on the floor of the tube where the broad ligament is attached. It is commonly met in ischemic implantation. Now, tubal perforation. Fate of the secondary abdominal pregnancy. Death of the blastocyst. Complete absorption. Massive intraperitoneal hemorrhage due to placental separation. Infections. Fistulous communication with bladder or umbilicus. Fetal death as a result, this by mummification, suppuration, adipocele formation, and calcification. And sometimes it continue to term pregnancy. The rate is only 1%, but if there is the pregnancy continue, there is more chances of fetal malformation, fetal deformation. Secondary broad ligament pregnancy. Rarely pregnancy may continue in same process as in abdominal pregnancy between the two layers of the broad ligament. So it becomes a broad ligament or intra-ligamental pregnancy. This is mode of termination. This is a chart of mode of termination of the pregnancy by tubal mode, either complete reabsorption or abortion. This leads to formation of the pelvic hematocele. Tubal abortion, it may be complete abortion or incomplete abortion. Tubal rupture, if the rupture occurs from the roof, it leads to diffuse intraperitoneal hemorrhage. If from the floor, it leads to intraligamental hematoma formation. If there is tubal perforation, if root by root, it may lead to formation of the secondary abdominal pregnancy if pregnancy continue in abdominal cavity. Or if flow, it leads to secondary ligamental pregnancy. But continuation of pregnancy in case of tubal ectopic is very rare. Sometimes it may occur in abdominal pregnancy or sometimes in ovarian pregnancy. Now, these are the various diagrams which show various fate of the ectopic pregnancy. There is tubal abortion, expulsion of the tubal pregnancy occurs through the abdominal ostia of the tube. This is rupture of this is a laparoscopic picture of the ruptured ectopic pregnancy. You can see the fallopian tube is ruptured and there is a big unruptured. This is a laparoscopic view of unruptured ectopic pregnancy. You can see this is tube. This is distended because of ectopic pregnancy. This is uterus and this is ovary. What is Arias-Steiner reaction? It is present in 10 to 15% cases of ectopic pregnancy. There is, because of high level of the hormones, there is increased thickness of the endometrium. This and the cell shows loss of polarity, pleomorphism, and hyperchromatic nuclei. Clinical feature of ectopic pregnancy. Ectopic pregnancy may present as acute ectopic pregnancy, subacute ectopic pregnancy, and unruptured ectopic pregnancy. Now, what is acute ectopic pregnancy and how it presents? It is associated with cases of tubal rupture and tubal abortion with massive intraperitoneal hemorrhage. Patient usually in reproductive age group and prevalence is mostly limited in nulliparous and following long period of infertility. Mode of onset, usually patient present with persistent unilateral pain. Classical triad of symptom in case of ectopic pregnancy, ruptured ectopic pregnancy is pain, amenorrhea, and vaginal bleeding. It is usually present in 50% cases of ruptured ectopic pregnancy. Pain is most constant feature which present in 95% patient. It may be of variable severity and nature. Amenorrhea present in 60 to 80% of the patient, not in 100% of the patient. Usually ectopic pregnancy rupture early, in between 4 to 8 weeks of the pregnancy before the diagnosis of pregnancy. So every patient you cannot find amenorrhea. Okay, so it present only in 60 to 80% of the case, but pain is a constant feature of ruptured ectopic pregnancy. Vaginal bleeding may be present. It is scanty or dark brown in color. Feeling of nausea, vomiting, fainting attacks, syncopal attack is present in only 10 to 15% of those patients. It is due to reflex vasomotor disturbance. What are the signs? While looking the patient, you will find patient is pale. There is feature of shock present. Patient has low BP. Patient is pale, low BP, pulse, tachycardia present, cold and clammy skin. On examination, usually patient is restless. If patient look blanched, pale, there is sweating with cold and clammy skin. Features of shock are present. That means patient has hypotension and tachycardia. On per abdomen examination, because of formation of the hematoma inside the peritoneal cavity, abdomen is tense, tender in the low, especially in the lower part of the abdomen. Shifting dullness is present. Rigidity may be present. For a speculum examination, you can see mild or scanty bleeding is present. For a vaginal examination, usually it is very painful, so you cannot find anything. Otherwise, uterus may be bulky, deviated to the opposite side because of a mass, unilateral mass. Fornix are very tender. There is excruciating pain on the movement of the cervix. POD may be full, uterus float as it is in water because of formation of the hematocele inside the peritoneal cavity. Now, unruptured ectopic pregnancy, how it presents? Usually, it is difficult to diagnose unruptured ectopic pregnancy, but you have to think about unruptured ectopic pregnancy when patient present with pain, amenorrhea, and the pain is unilateral, dull pain. Okay, so high degree of suspicion and ectopic conscious by only these two methods, a clinician can diagnose an unruptured ectopic pregnancy. Diagnosed accidentally in laparoscopy or ectotomy when we do any procedure because of pain or we suspect other type of benign ovarian tumor. Clinical features of unruptured ectopic pregnancy. Patient usually have delayed period, amenorrhea, spotting with discomfort in the lower abdomen. On per abdominal examination, there may be mild tenderness in the lower abdomen, usually unilateral. Per vaginal examination should be very gentle because it may rupture a unruptured ectopic pregnancy. Uterus is normal size, form is pulsatile, small, well circumcised, tender mass may be felt in the fornix. Now, chronic ectopic pregnancy. It is usually diagnosed by high clinician suspicion. Patient had various previous attack of acute pain from which patient has recovered. Now, the patient has dull abdominal pain that is persistent and with bladder and bowel discomfort like dysuria, frequency, retention of the urine, and rectal tenesmus. On examination, patient look pale. There is varying degree of the pallor is present. Temperature is slightly raised, and features of shock are present absent. Usually, in acute rupture ectopic pregnancy, usually patient present is shock, but in chronic rupture ectopic pregnancy, usually shock is absent. For abdominal examination, there may be tenderness, muscular guarding, and rigidity may be present. The mass may be felt that is irregular, tender. Pullen sign may be positive because there is dark bluish discoloration around the umbilicus. That is called Pullen sign. For vaginal examination, vaginal mucosa become pale. Uterus may be normal in size but may be bulky, and there may be a mass felt so the posterior lateral fornix extended to the pouch of Douglas, or uterus is shifted to the other side of the mouth. Now diagnosis. How we can diagnose a rupture ectopic pregnancy. So first, urine pregnancy test in patient is positive. Up to 95% of the cases. Condicentesis. It is a simple and safe procedure can be done by 16 to 18 because of the lumbar puncture needle through the posterior fornix into posterior corpus. There is formation of hematoma in rupture ectopic pregnancy. So most dependent part of the peritoneal cavity is the pouch of Douglas where all the blood accumulates. So when we take a lumbar puncture needle and insert it through the posterior fornix by holding the posterior cervix, and when we take, if the tap is positive, that means if we can collect a non-clotting blood through the posterior fornix around 0.5 with high XR, high hematocrit, that means tap is positive. This is the diagram how we can perform culdocentesis. We can take in this process, we take a needle, we insert this needle into the fornix and we suck out the blood. Now, other investigation which are more important nowadays is transvaginal ultrasonography. It is very sensitive method. It detects intrauterine sac at 4 to 5 weeks of the pregnancy, and when the beta HCG level is more than 1500 international unit per liter. Transabdominal sonography can also detect, but the sensitivity of the detection by transabdominal sonography is slightly less as compared to transvaginal sonography. Color Doppler improves the accuracy for diagnosis. It can identify the shape of the placenta that appear as ring of fire pattern because of increased blood flow outside the uterine cavity. Bagel USG picture how a ectopic pregnancy appear in USG ultrasound. There are some signs by which we can diagnose a ectopic pregnancy. Bagel sign, hyperechoic ring around the gestational sac and nasal visa. So chorionic activity appear as hyperechoic ring. So if this gestational sac is present outside the normal uterine cavity in adnexal, we can find a hyperechoic ring present in adnexal that is called Bagel sign. Blob sign, seen as a small conglomerate mass next to the ovary with no evidence of the embryo. Adnexal sac with fetal core and cardiac activity is the most specific sign for diagnosis of the ectopic pregnancy. These are USG pictures of the ectopic pregnancy. You can see this is gestational sac, this is hyperechoic ring around this gestational sac outside the uterine cavity. In this picture, you can also see this hyperechoic ring. HCG assay. Single beta HCG assay has little value, but if we repeat or we do serial beta HCG, then it can give an idea about the pregnancy, whether it is intrauterine, whether it is extrauterine, whether it is live intrauterine pregnancy, or whether it is whether it is live uterine intrauterine pregnancy or whether it is not in non-live or whether it is a dead intrauterine fetus. Serum progesterone. If the level of serum progesterone more than 25 nanogram per ml, it is suggestive of normal intrauterine pregnancy. If the level is less than 50, it suggests ectopic pregnancy, or if the level is less than 50 nanogram, it indicates non-viable pregnancy irrespective of its location. Diagnostic laparoscopy is gold standard for the diagnosis of ectopic pregnancy. It can be done only when the patient is hemodynamically stable. It confirms the diagnosis, and removal of the ectopic mass can be done at the same time. Now DNC. Intrauterine curate is performed when the pregnancy has been confirmed to be non-viable and the location of the pregnancy cannot be diagnosed by ultrasonography. It is essential to confirm the presence of plastic tissue as rapidly as possible so that therapy may be instituted. So what is gold standard for the diagnosis of extrauterine pregnancy? If there is UPT is positive, and if intrauterine pregnancy is absent, and if there is doubling of the beta SCG, failure to double beta SCG in 48 hours. So these two factors can tell us that intrauterine pregnancy is not present, the pregnancy is ectopic pregnancy. So two factors only: absence of intrauterine pregnancy by ultrasonography and failure to double beta SCG in 48 hours of the time. What are the differential diagnoses for ectopic pregnancy? What are the differential diagnoses for ruptured ectopic pregnancy? So ruptured corpus luteum of the pregnancy is also present symptoms like the ectopic pregnancy. Rupture of the chocolate cyst, twisted ovarian cyst, these are conditions present with the pain and sometimes with vaginal slide and anal bleeding. Torsion, degeneration of the pedunculatus, fibroid, incomplete abortion, acute appendicitis, perforated peptic ulcer, renal colic, splanchnic rupture. Differential diagnosis of chronic ectopic pregnancy. As chronic ectopic pregnancy present with dull abdominal pain and the patient is stable, so condition like pelvic abscess, pyositis, subserous uterine fibroid, salpingitis, retroverted gravid uterus, and appendicular lump may present as ectopic pregnancy, like symptoms like ectopic pregnancy. Now, how will you manage a ectopic pregnancy? First, take detailed history of the patient, evaluation for the high risk factor in examination, do a urine pregnancy test, ultrasound scan, transvaginal is preferred. Be ectopic minded, that means you should think about the ectopic pregnancy. Some clinical features present and beta SCG is negative. Repeat, then what we have to do? We should repeat beta SCG after 1 week. If it is negative after 1 week, pregnancy is excluded. If some clinical features are present and beta SCG is positive, do an ultrasound examination. If the discriminatory zone for beta SCG on transvaginal abdomen is more than 1500 milli international unit per ml, in this condition, if the intrauterine sac is present, determine viability. Beta SCG increased more than 60% after 12 or 48 hours. If serum progesterone is more than 25 and repeat USG intrauterine pregnancy is present, then it is live intrauterine pregnancy. If the uterine cavity is empty in this condition with adnexal mass, do a laparoscopy on ruptured ectopic pregnancy will be present. If the beta SCG is positive, strong clinical features of ruptured ectopic pregnancy, patient is in shock and hemodynamically unstable, then do resuscitation and nephrotomy. Ruptured ectopic pregnancy है तो उनको self injectomy करना है. Okay? यदि unruptured ectopic pregnancy है, expectant management कर सकते हैं, medical management and surgical. In expectant management, what we will do? We do serial beta SCG monitoring first after first. If in expectant management, initial beta SCG level is less than 1000 international per liter, if further beta SCG level is falling, ectopic mass diameter is less than 4 centimeter and there is no cardiac activity and there is no bleeding or rupture on transvaginal condition, patient is hemodynamic. Only this condition, we do expectant management. Medical management, whether by local or laparoscopic guided, we insert methotrexate, potassium chloride, we can give locally into the gestational sac, or systemic, we can give methotrexate 50 mg per meter square IM, or we can give actinomycin systemic for the medical management of the ectopic pregnancy. Surgical management is required in case of ruptured ectopic pregnancy and when medical and surgical management is not possible. It may be surgery may be of conservative type, expressing out from the distal tube, salpingostomy, salpingotomy, or segmental resection. Salpingotomy. And definitive surgery is salpingectomy or segmental resection. After any method of management of the ectopic pregnancy, after treatment, we should follow the patient with beta SCG, serial beta SCG monitoring weekly until it becomes negative. The management of ruptured ectopic pregnancy. First, the principle of management of ruptured ectopic pregnancy is resuscitation and laparotomy. First, start anti-shock treatment, insert IV cannula, IV line, slide is started. Blood sample should be sent for grouping and cross matching and blood coagulation profiling. Police catheterization is done, provide for the volume displacement. Laparotomy principle is quick in and quick out, rapid exploration of the abdominal cavity. Salpingectomy is definitive surgery, but transfusion is required in this case. Auto transfusion only when the donated blood is not available. This is a diagram of ruptured tuber pregnancy. Management of ruptured ectopic pregnancy may be expectant, medical, surgical, conservative. Surgery may be conservative or ablative. Expectant measurement, we only observe, do not do anything. Okay, what are the conditions in which we can do expectant management? So for expectant management, these conditions should be present. First, beta ECG level should be, initial beta ECG level should be less than 1000 international unit and consecutive levels should be falling. Gestational sac diameter by diversity should be less than 4 centimeter. No FHS on transvaginal ultrasonography. Conservative management can be done either by medical management or by surgical method. Advantage, it decreases the operative morbidity, there's less risk of recurrence. Medical management. What are the indications of medical management? If the patient is hemodynamically stable, serum beta SCG less than 3000 international units, tubal diameter should be less than 4 without any cardiac activity, there should be no intraperitoneal hemorrhage, patient should be hemodynamically stable. It includes under ultrasonography or laparoscopic guidance, methotrexate injection, potassium chloride, prostaglandin injection, hyperosmolar glucose, or actinomycin. Systemic methotrexate. Conservative surgery indication full, it's not fulfilling the criteria for the medical management. Okay. So when there is, we cannot do medical management, we will do conservative surgery. Or if beta SCG level is not falling in spite of the medical treatment and there is persistent of the cardiac activity of the treatment. Surgical method include salpingostomy, salpingotomy, segmental resection and anastomosis of the tube, and fimbrial expression of the ectopic pregnancy. Salpingotomy, we give a small incision on the ampullary part and over the anti-mesenteric border, and products are removed by finger or scalpel handle, and we do general section and irrigation. Linear salpingotomy incision is closed in this Incision is not closed in case of salpingostomy, but in sagittotomy, after giving incision and removal of the product, the suture is incision line. Segmental resection and anastomosis in the patient have rupture stomach